It is now 9/17/2020. We are in our lecture for RT210J, hyperinflation and obstructive versus restrictive diseases. On yesterday, we talked a lot about IS and IPPB, and I told you I was going to follow up with a few things before we go into obstructive today. I'm going to share my screen. All right, today we want to kind of touch on a few things that have to do with basic ventilator modes and the difference between trigger and cycle. The basic ventilator modes, because an IPPB machine or the older IPPB machines were used with the Bennett PR2 and the Bird Mark 7, and they were some real rudimentary ventilators. Okay, they were used for IPPB, but they could very well be made to be used as a ventilator, especially if you're a respiratory therapist who knows his or her parameters, what they mean, and what's important. Then you can make it into a ventilator, because that's basically what they were. Again, we don't use them anymore. Very rarely you may see one in maybe some of the rural hospitals. They mostly use the IPPB as far as metanib. Okay, the metanib, which I showed you in the lecture from yesterday. All right, so some of the basic modes. You want to get a little introduction to ventilator modes, right? Assist mode, assist control mode, fully control mode, pressure cycle, and trigger. Okay, the pressure cycle and trigger are not modes. The modes that I want you to think about are these: assist, assist control, and control. That's what we're going to talk about first. Assist mode is the mode that would be used for positive pressure breathing or intermittent positive pressure breathing. In this mode, the patient sets the rate and the machine delivers that rate. Okay, if you and the thing is, it's used to give the inspiration or give the volume, but the patient has to trigger that volume. If you looked at the lecture from yesterday, I told you that trigger means to start inspiration, and to end inspiration means to cycle. Okay, end inspiration means to cycle. And so in this, yes,
we can't see you.
I don't have my camera on.
Okay.
As long as you can see the you see the lecture, right?
Yeah.
Okay. Yeah, so assist mode, when the patient triggers a breath, the machine will give that pressure that I have set, okay? Because this is positive pressure breathing. We're trying to hyperinflate the lungs. So when the patient triggers the breath, it depends on how sensitive the machine is, okay? So the thing that controls the ability of the patient to trigger a breath is the sensitivity, right? Make sure you write that down, highlight that. The parameter that affects how much pressure the patient has to pull on in order to trigger a breath is the sensitivity. I can make the machine very sensitive, and the patient, all they have to do is just kiss on the machine and it will give the breath. It will trigger a breath to them. Or we can make the machine less sensitive, and the patient would have to pull real hard, a real negative pull, in order for the machine to finally say, okay, you can have the breath. Okay, that can be very cruel to some patients who are on the ventilator, right? If they start to wake up and they're trying to trigger their breaths and the machine is too hard or not sensitive enough to give a breath, the patient could very well panic, because they may not be able to speak, they may not be able to look at you or tell you anything, and they're just sitting there suffering, okay? So when we trigger a breath, that is called the negative inspiratory force, okay? You're going to learn when you get into ventilators that the patient has to be able to produce a negative inspiratory force. That's called a NIF, N-I-F, N-I-F. And what that's saying is that the patient will have to be able to pull on the circuit, okay? When they suck in, when you take put it like this, if you have a milkshake from McDonald's, right? A lot of times those milkshakes are so thick that you have to suck really hard on the straw in order to get the milkshake, right? Well, that's the same concept for sensitivity and trigger, okay? If the milkshake is really, really thin, then all you have to do is just barely suck on the straw and you're going to get the milkshake, right? So that will be very sensitive. If the machine or the milkshake is really, really thick, then you're going to have to suck really, really hard in order to get the milkshake to come out, right? And so the sensitivity is set by the respiratory therapist. You want to give it just sensitive enough to give the breath, but not too sensitive that it auto cycles breaths, right? We can make the machine so sensitive that if they get close to it and start breathing near the mouthpiece, then it will start triggering breaths, okay? So we have to be very careful not to set it too sensitive, but not to the point where we make it so non-sensitive that they can't even trigger a breath, okay? So that's what sensitivity is. It's a negative pull by the patient, okay? A negative pull by the patient in order for the machine to trigger a breath, okay? So when you're sucking on the machine, either it's the IPPB machine that you're using, a regular Metanip, right? If they suck on the machine and it delivers a breath, well, if you suck on it, that's going to trigger a breath. Now that breath is going to continue to go into your lungs until the pressure is reached. When that pressure is reached, it's going to turn off, okay? The breath is going to stop, and that's called cycle, all right? So when you suck on the machine, you're triggering it to give you a breath, right? And it's going to continue to fill up your lungs, hyperinflate your lungs until the pressure that we have set is reached, okay? Once that pressure is reached, the machine is going to stop or cycle off, okay? So for instance, if I set the patient on 30 centimeters of water of pressure, and that's what I have my positive pressure machine set to. I set it to 30 centimeters of water, and that's what I want to do for that patient, okay? Every time he or she triggers a breath, it's going to fill the lungs up until it reaches 30 centimeters of pressure, okay? Centimeters of water of pressure. Once that 30 centimeter water of pressure is reached, the machine will then cycle off. It will stop, okay? That will be the end of the first breath, right? You'll let them catch their breath a little bit, and then they'll do it again. Slow, deep with an inspiratory hold, right? So as soon as you suck in a little bit, the positive pressure is going to fill you up. You don't have to keep pulling, right? You don't have to keep sucking on it. Once you trigger the breath, all you got to do is let the machine hyperinflate you. That's when we're doing positive pressure, right? When we're doing positive pressure, all you have to do is trigger it, and it will fill your lungs up. It's going to pop them lungs open for you, all right? And it's going to do that until it reaches the pressure that I have set for it. If I set it on 20, it's going to cycle off at 20. If I have it set at 30, it's going to cycle off at 30. If I have it set at 40, it's going to cycle off at 40. So keeping in mind of what we talked about yesterday, that's another reason why you have to monitor the patient, because you might be giving them so much pressure that it's blowing off too much of their CO2, right? And then they start having these problems right here, like we said, dizziness and tingling, right? Or they may feel numb around the lips, right? Their lip areas may be numb. Those are all signs of hyperventilation, okay? Those are signs of hyperventilation. So you have to watch the amount of pressure that you put or you set for the machine, okay? Now, the pressure is set is a prescription. So when I do IPPB or positive pressure breathing, the doctor will set a pressure that they want to achieve. And then the therapist will work toward that pressure. So he may say, or she may say, I want Mr. Smith to do hyperinflation therapy, and I want them to get or generate 40 centimeters of water pressure. That's how much I want you to push into his lungs in order to hyperinflate him, right? Well, you might not be able to do 40 right off the bat, right? That's a lot of pressure. You might have to start a little low and work your patient up to that 40 centimeters of water, right? And so that's how you have to really coach your patient. You have to watch out, looking for signs that we talked about yesterday, right? Look for those signs of adverse reactions, knowing when to stop and what to look for, okay? So with that being said, we understand that the parameter that is set by the therapist that negates how much pressure the patient has to pull on the machine in order to trigger a breath is the sensitivity. Okay? All right. Now, again, assist mode, if we were using one of the old ventilators, in order to do IPPB, and that's all we want. We don't want to ventilate them. We just want to hyperinflate them, right? We will put them in assist mode that would, every time they trigger a breath, it's going to push that breath into them and stop, right? Or cycle. If the patient does it 20 times a minute, they're going to get it 20 times a minute. If he does it 5 times a minute, he will get it 5 times a minute. If he does it 100 times a minute, it will give it 100 times a minute. That's what it means. Number 2. Patient sets his own rate, right? And the machine gonna give it. Every time you suck on it and trigger a breath, the machine is going to deliver that breath, okay? That's assist mode, all right? Now, other modes that are in basic ventilator modes that we don't use for IPPB, right? The only mode we use for positive pressure hyperinflation, right? IPPB, AKA PPB, or AKA hyperinflation positively, right? Giving positive pressure just for hyperinflation is assist mode. That's the only mode we use for this, okay? Now, the other 2 modes that I want to touch on would be assist control and control. If a patient is in assist control, then that is used for conscious or continuous ventilation. That's somebody who cannot breathe on their own. They are on life support, and we are delivering them breaths, volume, oxygen, right? And we're delivering it constantly, right? So I'm going to stop my share and show you something on the board. What?
What part of this relation?
Yeah, I'm showing you this. It's in there. You might not have this wrote down. You have to write this down. Yeah, it's the last little bit that talks about the basic modes. All right, I'm going to show you some of these, what these basic ventilator modes look like. All right, so assist control, guys, would be we would deliver a, let's just say air. Assist control would give a respiratory rate, a tidal volume, an FiO2, and a P. Okay, those are the things we give with assist control. In assist mode, it's only a respiratory, we don't give anything, matter of fact. In assist control, on assist mode, that's what we use for IPPB, right? You don't give them a rate, you're not giving them a volume. The only thing we do is set a pressure. So for assist mode for hyperinflation, all we're going to do is give a set pressure only. Get another marker. This one's going out on me. Yeah, like that. Yeah, for assist mode for hyperinflation only, we give set pressure, right? Whether that's 20 centimeters of water, 30, 40, that's about high as they go, just for hyperinflation. So as soon as the patient triggers a breath, it's going to give them the breath. Matter if they give it 4 times a minute, 100 times a minute, or whatever, okay? But, and this is for hyperinflation, all right? This is it. Only one we use for hyperinflation. The assist mode, if we were doing it on a older unit, the old PR2 or the Bennett or the Bird or something like that, which we don't use anymore, but you still got to know that. Now, assist control is a mode that's used for continuous ventilation. This person is sedated and needs to breathe. You got to breathe for him. Respiratory therapy will be the one that's breathing for him, okay? Controlling his ABG, all right? So we would give a respiratory rate, tidal volume, FiO2, and a P, okay? In assist control, the patient can trigger breaths on top of what I have set, but if they don't breathe, it's going to give what I have set, okay? So say I got them on 12, 500, FiO2 of 40%, and 5 of P, all right? Well, if I do assist control, now this is not for hyperinflation, this is on ventilator. I'm just trying to show you real quickly the assist control mode if they were on continuous ventilator, right? Of life support, respirator, that machine that you will be manipulating. That's your job, is that machine, not the nurse. It's your job, okay? So if you set them on respiratory rate of 12, tidal volume 500, 40% FiO2, and 5 of peak, that means the patient's going to get 12 breaths per minute, and each breath will be 500 mLs of tidal volume, and it will give 40% oxygen with each breath and 5 of P, all right? Now, if the patient triggers more breaths in assist control, it will let you trigger some more breaths, okay? That lets us know that the patient is waking up, right? Because when they were knocked out, this is all he was doing. You look at the machine, I got him set at 12, and all he's doing is 12. That means he's not breathing over the machine at all, okay? But then as he gets better, and you look at the total respiratory rate, and it says his total respiratory rate was, let's just say 20, right? Well, how many breaths is he breathing on his own? Because I'm giving him 12, but his total is 20. 8. So that means 8 breaths are spontaneous.
So when they start breathing abuse the machine, do we go ahead, do we ease the breath like the
Yes.
respiratory rate down?
Once the patient starts, when they're in assist control and you got them set on some settings, right? And you see that they are starting to wake up and they're starting to breathe over what I got set, then we start to consider weaning. That's when you start weaning. And we have another modes that we go to before we take it off, okay? We will go down to maybe SIMV, right? Then we go down to just spontaneous where we give a little pressure support. After they do that for a while, we take it off and put on a what? T-piece, right? We do T-piece trials, right? If he can live with the T-piece, now we can decide to pull the tube, all right? So they go from completely knocked out, right? Sick, whatever shot, whatever the problem is, and they're not breathing over the ventilator at all. But when they start breathing over the ventilator, we start backing down off of our support. Okay, we start, if you're gonna do it, then we're gonna let you do some, we do some. You do some, we do some, right? And the more you do, the less we do, until we get to the point where we can wean them completely and take the tube out, okay? But you'll learn that in ventilators, that's not for today. But the bottom line is assist control, you have a rate, a volume, a FiO2, and a P. In assist control, the patient can trigger his own breaths, all right, on top of what I have set. But say he starts triggering some more breaths, he got 20, he's doing 8 by himself, but then he digresses and stops breathing. He's still gonna get what I have set. This is guaranteed. 12 breaths and 540% and 12 times a minute is guaranteed because I have it set. Okay, if he breathes more, it'll give him more. But if he stops, he's still going to get this no matter what. Okay, this is like a backup rate. Once he starts breathing on his own, good. But if something happened and he gets sick and he go back out, then he's still going to get this no matter what. You understand? All right. The next one is control mode. Now, control mode was found to be a little cruel, right? Because in control, which is CMV, control mechanical ventilation. You're going to have a rate, respiratory rate, a tidal volume, FiO2, and a P. So just say I got them set at 12, 500, 40%, and 5. In control mode, the patient cannot trigger his own breaths. So if he wakes up, say he was sick, coronavirus had him down, right? And we had him on controlled ventilation, breathing for him. He wasn't breathing over the vent or nothing like that. He starts to wake up and starts pulling on the circuit, right? He's pulling that negative force I was telling you. He's trying to trigger a breath, but the machine says you can huff and you can puff, but I ain't giving you nothing, okay? When you're in control CMV, they cannot trigger their own breath. So they start to panic, because if they want more than 12, they can't get more than 12. The only time they can get more than 12 is if I or you as the respiratory therapist notice, hey, he look like he's trying to get more breaths. He's waking up. Then I switch from CMV down to assist control, or down to SIMV or spontaneous. We start weaning, okay? But you never know when a patient wakes up. It could be 3 o'clock in the morning and he start coming to and start pulling. If you're not in the room, you're not going to know. All right, now it might start bucking the machine. He starts making, he'll start trying to push against the machine. And it's going to start setting off alarms on your machine. That's going to trigger you to come and see what's going on. But if he's weak, he may not be able to generate enough to force an alarm, okay? So we don't use this anymore. They ain't gonna kill you, no, because it's still gonna give you the breaths. It's gonna give you this, guaranteed. But when you want to, yeah, but it's gonna give you 12 breaths a minute if you got to set it. If you got to set it 20, it's gonna give 20 a minute. Whatever you set, that's what he's gonna get in CMV. If you set this in assist control, that's what he's going to get. But in assist control, it would allow him to kick his own breaths or trigger his own breaths, right? Trigger cycle. You got to keep that in mind. Assist mode only is simply for hyperinflation. They're going to trigger 1,000, they get 1,000. They trigger 1, they get 1. That's it. They're spontaneous, they're wide awake. So they're not having a problem with breathing. Controlled mechanical ventilation. All right. Okay. Controlled mechanical ventilation. We hardly ever use this one anymore because it's kind of, it's cruel. If the patient wakes up and trying to get some breaths, they're not going to get it. You can huff and you can puff, but you won't get anything from me. You're only going to get this 12 or this 15, whatever I have set. This is a setting. These are doctor's orders right here. The ventilator orders or settings are an order. You can't just go do what you want to do. All right? These are orders. These control the ABG, which you're going to learn when you get to ABG management. How do we control the ABG? So for instance, if I have a CO2 problem, it's a ventilation problem, right? So I'm either going to need more or less volume or more or less rate, because it all depends on me blowing off too much or not blowing off enough. So if I look at, I have him set on this and his CO2 is 65, he's not blowing off enough. I need to up this, right? Go up on the volume or go up on his respiratory rate, right? So he'll blow off more. And then I get an ABG later and it may show that his CO2 has now come down to 40, right? That's how you manage an ABG with the ventilator. You manage his CO2 with these two, PaCO2, right? And then these two, you manage the PaO2, right? When I'm managing the ventilator, managing an ABG, if it's a CO2 problem, I'm going to focus on respiratory rate or volume. If it's a oxygen problem, I'm going to focus on FiO2 or P. And you'll learn which one to do first when you get into ABG management and ventilators, okay? But this is your basic touch of it now. So when you see it again, you'll understand how do you manipulate the ABG for the ventilator. Notice I don't have bicarb in there because respiratory can't fix metabolic issues. If it's a metabolic problem, the nurse must fix it. Okay, they're going to either have to give them some bicarb or give them some fluid. All right. So, CMV, the patient cannot trigger his own breath. He's going to get what we have set, and that's it. Okay. Assist control mode is going to give them a set rate, but the patient can trigger breaths on top of that rate. Okay. But for hyperinflation purposes, we only use assist mode, right? All it's going to do is going to sense them with the sensitivity that you said. It's going to sense them trying to pull on the breath, and it's going to trigger a breath and give it to them. It's going to continue to blow that pressure in until the pressure is reached, and it's going to cycle out. Okay? All right. Let's continue on. All right, so basically, same thing I just said. Assist mode is the only one we use for positive pressure, hyperinflation, or IPPD. Assist control is used for continuous ventilation. If the patient fails to set a rate, the machine will deliver the preset rate. I just showed you. When you have a preset setting, right? Whatever those settings are, that's what he's going to get. If the patient wants to kick in more breaths, it'll let him kick in more breaths. Okay, you want to, I got you set at 12, but you want to do 20. All right, do 20. Have at it, right? It'll let you do that, but it's still going to give you it set, okay? But for some reason, you fall back out and can't set your own rate anymore, and assist control is going to give you that preset rate, okay? Kind of a fail safe, right? And an apnea alarm will go off, and the machine will kick back into breathing what you have set, okay? Control mode, which is a control mechanical ventilation. In control mode, you are in control as the therapist. The patient cannot, the machine set rate and does not allow patient to alter the pattern. So if your patient is out and they've not been breathing over the vent, I don't care if they've been on the vent for 2 weeks and they have not breathed, not one breath over the vent. That means they're just pretty much comatose. And all of a sudden, they start trying to pull, right? And you notice that they're jerking and stuff in the bed trying to get a breath more than what's set. If they're in control, they're not going to get it. You will then start to come down on the support. And we call that ventilator weaning. You start the vent liberation process. When you become liberated from something, you're free from that, right? You got a relationship and you want out. You start doing things to get out and liberate yourself from that person, okay? And so when we have somebody on the ventilator, we want to liberate them from it. We want to get them off, okay? And we start weaning them as fast as we can because you can become vent dependent, all right? You be on the vent for so long that you want to stay on. Your body say, you're going to stay on this. I don't want to do it no more. You do it. And so you'll be stuck on the vent for life. You have people at home right now on the ventilator, okay? And it can come from damages of smoking. It comes from damages of drugs or any other thing that, you know, some kind of disease that you may have had, okay? Now, as we talked about, the cycle and trigger. Trigger means to get the breath. Cycle means the breath will stop, okay? So pressure cycle, all right? Cycle means whatever ends it, okay? Most machines are pressure cycled, all right? When the pressure is met, it will stop, right? If it's flow cycle, then when the flow is reached, the machine will stop, okay? If it's time cycled, when the time that you set is reached, the machine will stop, okay? Most of them are pressure cycled because we put the pressure in, we want to deliver a set pressure, and we don't want to go too high because we may cause barrel trauma, pneumothorax, any kind of problem, right? So we want to know how much pressure we're putting in those lungs. So most of the time, IPPD machines are pressure cycled. That means it ends with the pressure that's reached. All right. So for instance, if I set Mr. Johnson on IPPD and I set him on 25 centimeters of water of pressure, but once the manometer reaches, when he sucks the breath, he's going to pull on it and it's going to trigger that breath. He's just going to let it fill him up. And as he's filling it up, the machine is reading the pressure in the lungs. As that pressure gets to 25, boom, it's going to stop. As soon as it gets to 25, boom, the pressure, the whole breath stops, okay? Because that's what I got it set on. I wanted to stop at 25. When it gets to 25, it's going to stop. If I have it set on 40, when it gets to 40, it's going to stop, right? If I have it set on 15, when it gets to 15, it's going to stop, all right? Now, if it's other reasons for it to cycle, okay? Look at A. A says cycling is what ends inspiration. When the set pressure is reached, the machine ends inspiration. There are some other possibilities for cycling, right? Flow cycle, time cycle, or volume cycle, okay? This depends on the machine that you have. So if you have a machine that is time cycled, so you might say, okay, in 1.5 seconds, I want the breath to stop. So he's going to trigger the breath, right? He's going to suck on it. You're going to set the sensitivity to where it's easy for him to get it, right? And so just for instance, not this part, but just showing you this part for demonstration. If the patient has this is hooked to a positive pressure machine. Well, when I do that, I'm pulling negative force, right? The machine reads that force that I'm pulling, and if I reach the sensitivity that you have set, it's going to give me the breath. But if I'm cruel and I say I'm going to make him work for this breath, I can turn the sensitivity way down, right? And it's harder for you. So you be, right, pulling on it, and it still won't give you a breath, okay? That's being cruel, right? But I can change that with the sensitivity. If I make it very, very sensitive, then all you have to do is just kiss on it, right? As soon as you come to it and pull a little bit, it's going to give you that breath, okay? That's what you want. You don't want it too sensitive, that because sometimes if they just get close to it, it'll blow in their face because it can feel your breath that close. They can be that sensitive. Yes, you are setting the sensitivity so that Mr. Johnson can get the breath without struggling. You turn the sensitivity knob. The more sensitive you make it, the easier it is for him to get the breath. The less sensitive you make it, the harder it is for him to get the breath. So if you make it really, really non-sensitive, then now he'll have to pull, and still won't get the breath, or finally get it after he pulled it. Well, you don't want him to have to do that. No. You don't want him to have to work that hard. If he doing all that just to get a breath, that's not what you want. Because this is a passive treatment, right? The machine gonna do the work. All he has to do is trigger it. So as soon as he pulls on it, he has to seal his lips around. You don't want to hang it out the mouth like this, right? Because all the volume is coming out. You're gonna have leaks, right? You want to make sure you have sealed lips, right? And if you have problems with your leaks, the first thing you want to do is put on nose clips, right? That's going to be a test question. The first thing you want to do to check for leaks or to work with leaks is put on nose clips. So your patient that's getting positive pressure will be like this. You have some little white clips that go on the nose because you don't want that air to come out the nose. We want the air, especially if it's positive, right? We're pushing air into the lung. It's going to escape wherever a hole is. So if it can feel like it can come out your nose, then it's going to come out your nose. If it comes out your nose, it's not getting in your lungs. The whole therapy is for naught, right? The whole purpose of this therapy is to hyperinflate the lungs to treat or prevent atelectasis, right? So if it's coming out his nose, it ain't going in his mouth. It's not going in his lungs, right? So we're wasting time. So you want to, if you have leaks, put on nose clips, okay? Set the sensitivity. All he has to do is barely pull on it, and it's going to give him the breath. You don't want to be here all day, him struggling, trying to get a breath, okay? And whatever cycles the machine, whatever machine you have, when it reaches that parameter, it's going to stop, okay? All right. All right, so that's the end of that one. We stop share. Now we're going to get into obstructive lung diseases. So we're going to take a break here. It's 1:45. Let's come back at 2 o'clock. 15-minute break here because we're going to get into this obstructive, and I'm not going to stop in the middle of the obstructive PowerPoint. You have the note-taking guide for obstructive. You just follow along with it goes right along with the PowerPoint. Okay, take whatever notes you need to take. Pause the recording here. We'll come back at 2 p.m. and knock out obstructive lung diseases. Okay? All right. All right, gang. Break is over with. We're going to now get into obstructive lung diseases. And before I get into that one, 3 things I want you to write down to make sure you have this, because there's going to be, of course, test questions that will kind of touch on that. And I want to make sure you see. If you've been reading and you've been studying, then you may know it, but I'm going to make sure. First thing is, the most important, let's just say, the most important aspect of in-center spirometry to ensuring that it is being therapeutically done, right? That it's working for the patient. The number one aspect of that would be RT instruction, okay? The respiratory therapist's instruction is the most important component to whether or not IS is working for the patient or not, okay? That's the first thing. Most important, first and foremost, they have to be instructed correctly by the RT. If the RT does not instruct it correctly, then it's not going to be done right, okay? Next thing, when doing a sustained maximal inhalation, also known as in-center spirometry, right? We're talking about in-center spirometry. The number of time or number of seconds to hold their breath is between 5 and 10 seconds, okay? So you would instruct your patient to take a slow, deep inspiration with an inspiratory hold, right? And following along with the way I told you yesterday in the lecture, and they're going to hold their breath. Well, you hold your breath 3 to 5 seconds. Okay? I'm sorry, 5 to 10 seconds. You want them to hold their breath 5 to 10 seconds. So if you get a question that says you should tell your patient to hold their breath at least how long? Well, you're going to say at least 5 seconds because the range is 5 to 10. But if they say at least, then that means the lower end, right? All right. And the last thing, when is it best to orientate your patient to IS if they're going to have surgery? When is it best to show them or teach them? The answer to that is before surgery, okay? Not after surgery, trying to explain a whole bunch of stuff to somebody who's sedated, right? But before he goes into surgery, you need to explain to Mr. Johnson about IS, what it's for, how to do it. Let him do a couple of them before he even goes. That way, when he comes out of surgery, he's already well-versed on how to use the IS, and it's easier for him to do it better, okay? So those are 3 things I just told you that you need to make sure you highlight because you will see them again. All right. Going on into obstructive lung disease. Share my screen.
you don't want no cookies and cheese there.
Huh?
Yeah,
All right, but I gave y'all the note-taking guide for. You should have the note-taking guide for obstructive disease.
Yeah, but no, she just asked that I have it. It's
Oh,
18
okay.
pages.
It says, yeah, obstructive disease.
It's one for obstructive and restrictive.
Mute your mic.
Oh,
I said mute your mic. All right, here we go. Obstructive diseases. We said from the onset that obstructive lung disease is when a patient has problems exhaling the gas, right? They can't get the air out, right? When somebody has an obstructive lung disease, they cannot get the air out. Hello? No. How may I help you? So I gave you guys a joke that what did the alveoli say? Or what did CO2 say to the alveoli? The CO2, what did the CO2 say to the alveoli? He said, you can huff and you can puff, but you'll never blow me out, right? Somebody has an obstructive lung disease. They can't get the air out. They trap air because they have lost their elasticity of their lungs. We said that when the lungs exhale, they kind of just come back because they have elasticity, right? But if you smoke, I said your lungs elasticity starts to look like what? Old what? Old draws, right? They have lost the elasticity. So you just look at some draws, they don't pop back at all, right? Or old scrunchie that females wear in their hair that you've been using since you've been in middle school, right? It has lost its elasticity, right? It just kind of hangs there, old rubber band. Those are the same way I want you to think of lungs that are COPD or obstructive lung diseases, all right? Now, COPD is made up of seabed diseases, okay? They're made up of a list of diseases. And if you have 2 or more of the diseases, you're considered to have COPD, all right? So the objectives, you'll be able to understand some pulmonary function test data for obstructive diseases, know the difference between obstructive and restrictive. Restrictive, you can't get the air in, and obstructive, they can't get the air out. So today we're going to focus on obstructive diseases, and tomorrow we will talk about restrictive, okay? All right. You also got to differentiate between and describe the manifestations and treatment for various obstructive diseases, okay? There's some treatments that we use for COPD, right? There's some gold standards that we always use. Now, I want you to write this down. The best way to treat obstructive disease or COPD is to have a well-rounded PFT. The best way to treat COPD is to first have a good pulmonary function study test done, a PFT. That's the only way we're going to know where we are, okay? It's kind of like you going to the bank and you want them to help you with saving. Well, the banker needs to know where we are, right? They need to do a nice test or diagnosis of your pockets, right? Let's see how much money do you have saved? How much have you been depositing, right? How much have you been spending? And they look at an overview of that to know where to start. Do we need to start as if you've never saved before? Or do they need to start as if you are a hoarder of money, okay? So you got to know where to start because COPD is in stages. You have stage 1, stage 2, stage 3, and stage 4 of COPD. So on somebody, you might not even know you had COPD, right? You may not see the doctor until you're well into stage 2 or 3, okay? But the doctor needs to know, or the respiratory therapist needs to know, how far along are you in your obstructive disease. And then that way we can treat you the best way. We don't want to spend time or waste time on something that I should have been treating for somebody who's in stage 1, right? And while I'm treating you with stage 1 drugs, you are getting farther and farther closer to death. Okay? If you at stage 3, I need to jump into dealing with you very aggressively to help you have a better way of life. Okay? So the gold standard, those very words, the gold standard in treating COPD is to first have a PFT. Okay?
That's pulmonary.
Pulmonary function test. All right, the C-babe diseases. Remember I said you got COPD, baby, right? COPD, baby. Cystic fibrosis. B for bronchitis or chronic bronchitis, right? Somebody has it all the time. A for asthma. B for bronchiectasis. E for emphysema. And the last B is bronchiolitis. Cystic fibrosis, chronic bronchitis, asthma, bronchiectasis, emphysema, and bronchiolitis. This little graph over here kind of shows you if you have COPD, if you have 2 or more of these, right? If you just have asthma alone, then you don't have COPD. But if you have asthma that comes from chronic bronchitis episodes or bronchiectasis that comes from cystic fibrosis, then you have COPD, right? If you have emphysema because of your chronic bronchitis and the tearing up and the inflammation, because bronchitis is itis, right? It's inflammation of the bronchioles or the bronchial tubes. And if you keep on having them, that inflammation starts to scar them and they start to lose their elasticity and the lungs become floppy, right? And so you ever seen the meat on somebody's elbow, an old person's elbow meat? You know how floppy that is? It's just like skin. That's how the lungs just lose. They're just there, right? And the whole term for floppy lung is emphysema. Emphysema is AKA floppy lung. Emphysema, we're going to learn where it comes from, what starts it, how to prevent it, all those things. So that's the CBAE. First thing, COPD again. You don't have to remember how many leading causes of death, how many people died, and how much it costs. But basically, it's a disease characterized by preventable, treatable airflow limitation that is usually progressive in nature, not completely reversible, and having some abnormal inflammatory response to noxious particles or gases. It don't always come from smoking cigarettes, right? But even though cigarettes are harmful, noxious gases, okay? But if you work somewhere that have harmful chemicals and you breathe it for years, that can cause damage to your lung to give you COPD, okay? It's the third leading cause of death behind heart disease. But we're not gonna go into all that. That's not, you don't have to know those parts. All right, the first COPD disease we're gonna talk about, the first CBABE disease is chronic bronchitis. Chronic bronchitis. Chronic means something that you always get, right? But chronic is described as chronic productive cough of unknown etiology. I mean, you don't know where it comes from. For 3 consecutive months for more than 2 consecutive years. So that means you got bronchitis in January, right? You had it January, February, and March. Then it finally went away, right? Then next year, you caught it again like in June. And you had it June, July, and August, right? You got COPD, right? It shouldn't last that long. That's why it's called chronic. Anybody has bronchitis for 3 whole months, that's a long time, right? And you got it twice in a year, that's COPD. That's chronic, huh?
So that means you have to have consecutively, or you can get it. And then
3 consecutive months, twice in 2 consecutive years. So you got it for 3 months 1 year, and then the next year you got it for 3 months again. Don't have to be the same months, but they have to be consecutive years and consecutive months. All right. Number 1 cause of bronchitis: smoking. Smoking. Repeated infections, occupational exposure, or air pollution. All of these things can cause it, but the number 1 cause for it is smoking. And don't get it twisted, because if you smoke weed in a cigar or a blunt, it is tobacco. So you might as well be smoking a cigarette. All right. So those that are smoking weed, I don't smoke cigarettes, I smoke weed. You just as floppy as somebody who smokes a pack a day of Pall Malls. If you're smoking in blunts, because that's tobacco paper. It's a tobacco leaf that's been made into paper, and you smoking it just like you are a cigarette. So don't be confused or fooled. I don't care if it's grape, peach, and all of them different flavors, it's still tobacco. How does it manifest? Bronchial mucus gland hypertrophy, right? The bronchial mucus glands get bigger, and hyperplasia, right? It's marked by thick gray sputum, right? Chronic bronchitis is marked manifestation. How I know that we got it? First of all, we said it lasts for 3 months, and you get it consecutive years. But another thing is thick gray sputum. So if you're coughing up thick gray looking sputum, that is chronic bronchitis. It usually happens in the morning, a nagging morning cough that becomes chronic. Okay? And we said, why do we have the morning cough? Why do we have the morning cough? The cilia have been paralyzed because of what? Smoking cigarettes. Good. Good. Excellent. So when you smoke cigarettes all day, you paralyze your cilia. So all that junk that you've been inhaling gets trapped on the gel layer of your mucus, right? Your mucus blanket. They get trapped, but they can't get moved to the airway to cough it out. So until you go to sleep. Now, when you go to sleep, you finally are not smoking. So the cilia finally wake back up and come back to life and start trying to hurry up and move all that stuff up to the mouth before you wake up and start smoking again. So you wake up, there it is, right there, the tip of your throat. And you start coughing up stuff. That's called a smoker's cough. A smoker's cough. Okay? It also manifests with increased infections. You're always getting infections and having to have antibiotics. The chest x-ray, CXR means chest x-ray. Chest x-ray shows dirty lungs, right? It's really, you won't know how to look at that at this point. All right? Polycythemia, that means increased red blood cell count. So COPD patients can have an increased red blood cell count. I've seen that on one of the tests as a multiple. It says, how do you know it's manifestations of COPD? And polycythemia was in there, and a lot of people didn't pick it. Polycythemia is one of the manifestations of COPD. Okay? Now, pulmonary function test. We already know that FEV is forced expiratory volume, right? So how do you expect somebody with COPD's forced expiratory volume to be, high or low? Low, because they can't get the air what? Out. COPD can't get the air out. So therefore, if I test how fast and how much can come out, it's going to be lower than somebody who don't smoke, right? Because they can't get it out. Now, they can get it in, but they can't get it out. So they're going to have a decreased forced expiratory volume. See that?
Mr. McCarthy.
Yes.
Did you go over the homework for last night?
Did I go over the homework?
Yeah, the homework we had.
Last night?
Yeah, did you go over it?
No, I didn't go over it.
Could you go over the answers at the end of class?
Yeah, I'll get with you at the end of class and go over it.
All right.
All right. All right. Treatment. How do we treat COPD? Well, first of all, we got to remove the patient from the irritants, right? If you smoke, stop smoking. If you are living somewhere or working somewhere where the irritants are causing you to have this, you need to look for another job or get some type of better respirator protection, right? So remove them from the irritants. That's the first thing. The next thing, gold guidelines for managing COPD. What did I say that was? What is the gold guidelines for managing early PFT? That's for all the diseases. All of them, all the COPD diseases are going to have gold guidelines for managing COPD, which is getting an early PFT. We treat them with SABAs and LABAs. What are those? There you go. Short-acting beta agonist drugs and long-acting beta agonists or beta-2 agonists, right? That's what that means, which are bronchodilators, short-term bronchodilators and long-term bronchodilators. We give them steroids, right? Because bronchitis is inflammation, and steroids treat inflammation. Antibiotics, because a lot of times they have their white blood cell count might even be up, so it might have to give them an antibiotic. Oxygen, a mucolytic, right? Diuretic, if they have water problems, you know, a problem with retaining the water, we can give them a diuretic. What is a mucolytic? Well, give me an example of a mucolytic, the drug name. What's one of those mucolytics? Say it again. Close, I think. Dexamethasone, that's a steroid. Give me a mucolytic. Remember, we had some mucolytics. One of them breaks the disulfide bonds of mucus. One of them raises the pH. One of them breaks the DNA. Say it again.
Is it Flovin?
Not Flovin. That would be a Flovin. I think is also a either a steroid or a long-acting. Give me a mucolytic. DNA, a deoxyribonuclease. That's a mucolytic. What's another one? Which one do I give? Which one raises the pH of the sputum? Which mucolytic raises the pH of the sputum? Sodium bicarb, right? Sodium bicarb, we can give that. What about the one that breaks down the disulfide bonds of the sputum? Smell like rotten eggs. No, you said the DNA one. Eucalyptus, acetylcysteine, right? All right, so we give them gold standards for the COPD. We give them short-acting and long-acting beta agonists. So that's like short-acting will be your bronchosol, your albuterol, your Zopanex, right? All of those. And then your long-acting will be your salmeterol and the Flovins and all of those that are long-acting beta agonists, right? We give them steroids like Symbicort, Pulmicort, Decadron, right? Antibiotics, maybe like gentamicin or tobramycin, remember, right? Oxygen, mucolytics like acetylcysteine or deoxyribonuclease, right? Or Dornase alpha, right? Which is pomazine. And then bronchial hygiene, that means getting rid of the stuff. So coughing up well, CPT, right? Postural drainage, right? All those things are bronchial hygiene to get that stuff up out of the lungs. The chest vest, all those kind of things will be used. And then finally, pulmonary rehabilitation, helping them learn how to have breathing exercises to help them strengthen their lungs back up. All of that is treatment for COPD. The next one, emphysema. Emphysema. Now, emphysema is a condition characterized by abnormal, permanent enlargement, stretched out air sacs, right? Might as well say, they're stretched out air spaces beyond the terminal bronchiole, accompanied by destruction of the walls of the air spaces without fibrosis. So floppy lung. Emphysema is floppy lung. The air sacs or alveoli have been stretched out, permanently enlarged and stretched. Old draws. Okay? The number one cause of emphysema is smoking. Notice how smoking is at the top of these. And your breathing with smoking can change overnight. You was all right, been smoking for years. I've been smoking for 10 years. I'm good. The very next day, you could wake up short of breath and never come back to how you was the day before. And COPD, guys, is irreversible. Damage to the lungs is irreversible. Damage to the brain is irreversible. You can damage your arm and get back. You can damage your stomach, other organs, and kind of heal them, right? But the damage to the brain, the damage to the heart, and the damage to the lungs are irreversible. So you can keep smoking if you want to. It's job security for me. All right. The next cause, long-standing obstructive disease. So like if you already had asthma and chronic bronchitis for a long time, they together can damage the lungs to the point where they become floppy. Once they become floppy, it's called what? Emphysema. Okay? So usually emphysema is brought on, it's caused by smoking, but the smoking gives you chronic bronchitis and some other things together. And once they start working together, damaging the lung, that damage is called emphysema. All right? You don't just smoke and then all of a sudden you got emphysema. Okay? You're going to have a couple of the other C-babe diseases first that will then produce damage to the lung, which is floppy lung, and that's also called emphysema. All right? Outdoor air pollution. Outdoor air pollution can destroy the lungs. Okay, and another thing, it can be genetic. Emphysema can come not even from smoking. That's the #1 cause, but it can come from not smoking. It can come from just genetic, and that will be a reduced level of alpha-1 antitrypsin. Okay. There's a protein in the body called alpha-1 antitrypsin that helps keep the lungs elasticity. But if you're born with low levels of that, then you automatically have emphysema from birth. Okay? You can have emphysema type problems from birth because you have a low level of alpha-1 antitrypsin. So of course, when you get these questions, they're going to say, which one of these cause emphysema? Which one of these cause chronic bronchitis, right? You're going to need to know which one is which. Now, emphysema has 2 types, okay? Emphysema has 2 types, panlobar and centrilobar. Panlobar happens from having that low alpha-1 antitrypsin. That's the panlobar, that's the worst one. If you're born with it, that's the worst one. Okay, panlobar. That's alveolar enlargement. It usually occurs in the bases of the lungs. Panlobar is the most severe case of emphysema, and it's usually caused by the alpha-1 antitrypsin deficiency. All right, Ms. Taylor, which one is the worst one? Which type of emphysema is the worst type? You gotta stay with me. It's too much. It's too much. Panlobar. Okay. The second type is centrilobar. Centrilobar emphysema is enlargement of the bronchioles. Okay, and that usually affects the upper portion of the lungs. Most common from, that's the most common form is centrilobar. That's the most common one, right? And it's caused by smoking or inhaling toxic irritants. So people who get emphysema from smoking, they get the centrilobar type, okay? People who get emphysema from birth get the panlobar type. Panlobar is the alveoli itself is stretched open. Yes, panlobar is the one that can happen from a low level of alpha-1 antitrypsin, and they said that's genetic. So if it's genetic, you got it from birth. Okay, it may not kick into a little bit later, but it's genetic. Okay. Also, some things to understand. Panlobar is the actual alveoli is big, right, or swollen, right, enlarged. But central lobar is when the bronchioles are enlarged, right? The bronchioles are stretched out or enlarged, okay? Two types of emphysema, all right? The most severe one is panlobar. The most common one is central lobar. How do we treat emphysema? Well, we got to get them out of the irritants. Again, stop smoking. Stop smoking cigarettes. Stop smoking blunts. Right? We treat it with the gold standard for COPD. What is that again, Ms. Taylor? PFT. Early PFT. We also treat it with SABA and LABAs. What's that, Rihanna? SABA and LABA. Well, I was asking Rihanna if she's still with me. But anybody, who else is on here? Judith, SABA and LABA. Can I help you? Who? What program? I think they're in that hall right there. Go up to that second door on your left. This way. Go up past that first door to that next door. Go over in there. Judith, can you hear me?
Yes.
What's SABA and LABAs?
The short-term and long-term medication.
Good. They're short-acting beta-2 agonist and long-acting beta-2 agonists, right? Because beta-2 agonists are the ones that give us bronchodilation, not beta-1. All right, good. Steroids, of course, oxygen, diuretics, pulmonary rehab, and we can give them some antitrypsin, alpha-1 antitrypsin. We can give them some synthetic, right? Give them IV synthetic alpha-1 antitrypsin. So we know that your emphysema is panlobar, and we know that it came from you having a low level of alpha-1 antitrypsin, then give them some, right? We give them some level 1 or alpha-1 antitrypsin. Give it to them, okay? This little chart over here, guys, is showing you the stages of COPD. Mild is stage 1, stage 2 is moderate, stage 3 is severe, and stage 4 is very severe. Patient can't even take a bite without running out of breath. Okay? You notice the FEV percentages, right? FEV, forced expiratory volume, in the first second. That FEV1 means forced expiratory volume in the first second, right? These are things we do with pulmonary function tests. They tell them no, blow, 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 blow. Well, we count that first second. The amount of air that went across in that first second is the FEV1, right? And then we do the FEV forced vital capacity. It's kind of like a ratio. Less than 70% is mild, right? If it's less than 70%, it's mild. Okay. We want it to be greater than 80%. That's what we want. But if it's less than 70, you have mild COPD. Okay. Then you have like 50%. If you're 50%, then you're considered moderate. And then 30% you consider severe, right? And then very severe is also 30%, but some other things as well. Plus chronic respiratory failure, right? That means your CO2 is always super high and you're having those issues, okay? You don't have to remember the stages. You will not be tested on stage 1 is what percent. We don't do all of that. I'm just showing you the percentages and how there are different stages for COPD. All right. The next one, asthma. Asthma. Asthma is primarily an inflammatory disease process with clinical manifestations of airway hyperresponsiveness, right? That means they close up, just look at them wrong. They close up. They're hypersensitive, hyper-responsive, right? Remember we said we have to be careful when we give bland aerosols to hypersensitive airway patients because we may give them some aerosol, just regular bland aerosol, and their body don't like it, and their bronchioles close up on you, bronchospasm, right? Because they're so hypersensitive. It says, and other airway obstruction, and it's partially or completely reversible. Now, asthma is reversible, asthma itself. But when it becomes damaged like emphysema, that is not reversible, okay? So if we treat it and catch it early, we can pull you out of that state, right? A lot of times they grow out of it, okay? But as long as you are doing the correct treatment, we can prevent or reverse the effects of asthma, but not the damage to the lungs. Once it's done, it's done. All right, the etymology, you don't have to remember where it comes from, how many people are affected and all of that. Causes, the things that cause asthma. Well, they can be an allergic response or non-allergic response, okay? Allergic responses to asthma are usually like pollen, animal dander, or dust mites. They can trigger, yeah, that's a dust mite, yeah, that's a dust mite. Dust mites are in the dust, and they can get into your lungs and cause a bronchospasm. Those are allergic reactions, right? The pollen, the pet dander, and the dust mites, what do they break down that causes an allergic reaction? What's the name of that cell?
Histamine.
The mast cell, good. Mast cell, and the mast cell releases the histamine, good. So anything that you're allergic to will break down your mast cell. Okay, and once that mast cell is broken down, the histamine gets into the system, causing contraction and secretions and all that kind of stuff, right? So that can be an allergic response for asthma, all right? But there are also some non-allergic asthma, right? Some things that ain't got nothing to do with them being allergic. It just can still cause an asthma attack. Chemicals, inhaling certain chemicals. Cigarette smoke, if somebody's smoking around you and you can't take it, you can have an asthma attack. Cleaning agents, right? It can smell good, but it could be strong, right? It can be real strong. As soon as you smell that ammonia or whatever, it causes you to have an asthma attack. Now, if you don't clean, you don't know what we're talking about. Aspirin. A lot of people didn't know that aspirin can cause an asthma attack. Taking aspirin. Chest infection, so that would be your respiratory infections. You can call it cold, right? And that infection can cause an asthma attack. Stress, being stressed out about corona, being stressed out about whether my kids are going to be able to go to school or not, stressed out whether I can go to school or am I sick, right? Am I going to bring it to my grandma? Stress can cause an asthma attack. Then laughing, you go to the comedy club and somebody just cracks you up and you get into a laughter fit and you have an asthma attack. It's possible. Cold air. Some people who live up north, you know, you come outside and it's 10 below zero and you breathe that hawk in and all of a sudden, boom, you have an asthma attack, right? So you have to be careful in cold air. Exercise, just trying to get in shape, right? And trying to stay healthy. Exercise can trigger a asthma attack. Exercise-induced asthma, yeah, that's exercise. Preservatives like ketchup and things that are saved up like canned goods and diced meat, cold cuts. They use a lot of preservatives. When you feed your children all these non-fresh foods, you can be contributing to their asthma attack. So if your child has asthma attacks a lot and you don't have any of these other things, but you see that you got a lot of cold cuts, a lot of canned food, a lot of ramen noodles, all that kind of preservative stuff, that could be causing it. You might need to change their diet, okay? Change their diet. It costs money to live right. It does. It's easier to buy those things so they're cheaper, right? But when you're trying to eat healthy and live healthy, it costs. All right, manifestations. Asthma manifests as partially or completely reversible airway bronchoconstriction. And why they say partially or completely, because when I take a SABA, right, which would be my rescue agent, I wouldn't reach for a long-acting bronchodilator if I had an asthma attack. I'm looking for my fast acting, right? The short acting beta agonist would be the rescue drugs, like my albuterol inhaler. I'm looking for the albuterol. I'm looking for the Zopanex. I'm looking for the Bronchosol. EpiPen will be for the allergic
I'm
actions.
not saying it's, I mean, the.
Racemic epi is also for allergic. It's also for allergic react or stridor, like when your throat swell up. But when you have an asthma attack, you're looking for the bronchodilators. Racemic epi is considered a slight bronchodilator because it has a little bit of beta 2, but it's mostly an alpha and beta 1 drug. Okay. Respiratory distress, right? The chest can feel tight. The chest just feel tight. Short of breath, start sweating, a really weak cough, and cyanosis. The asthma attack. Increased mucus glands causing thick secretions inside of you, right? Wheezing, right? That's the telltale sign of asthma is wheezing. If I listen to your breath sounds and I hear, right? That's wheezing. That's because look down here at the bottom. It should be, airway wall should look like this, right? But when you have an asthma attack, you have a thickened airway wall, and now you have mucus inside of here, so you have a small amount of space for air to travel through. So when you whistle, you can't whistle like this. Can you whistle like that? Are you looking? You can't whistle like that, right? But when you close that diameter, then you can whistle. Well, that's the only reason why your lungs whistle. It's because you have decreased the diameter of your airways, so now it sounds like a whistle. Okay? Chest tightness and cough. When we diagnose asthma, the doctor is going to rule out everything else. You cannot diagnose asthma from a chest x-ray. You can't. All you can do is try. Is my speaker on? I hear myself somewhere else. Your speaker on? Oh, okay. All you can do is rule out other things like bronchiectasis, bronchitis, right? You rule those things out. If they don't have that, then it's probably what? Asthma, okay? You can also look at their past symptoms. Shortness of breath. Did they have wheezing, cough? What about family history? Did my mama and my daddy got asthma, right? Eczema. A lot of people with eczema have asthma. That's a telltale sign of asthma if they have eczema. If they have eczema on their skin, very high chance that they have asthma as well. Might not just showed up yet, but it's probably there. Nasal polyps. Nasal polyps, those are little polyps up in the nasal, in the nerves. And aspirin intolerance. Remember we said aspirin can cause a asthma attack. I heard an echo from somewhere. All right. Laboratory, of course, we do a PFT to see your flows and your volumes. We do a chest x-ray to rule out other things, right? And broncho provocation, you don't have to worry about that. Classifications of asthma, you don't have to, you can go back and look at these just to know, but there's an intermittent, mild, moderate, and severe asthma. This kind of gives you some symptoms that you may see to be able to tell whether you or your child asthma is either just every now and then, is it mild, moderate, or severe? But this classification is not on the test. Now, asthma status asthmaticus. I love that word. Status asthmaticus is an acute exacerbation that does not respond to therapy. So you come into the ER with an asthma attack, and I give you a short-acting bronchodilator. I gave you a steroid, right? I'm giving you everything I can give you, and you still are locked up. Your lungs are still closed or bronchospasmed. You're still wheezing. You're still short of breath. You're still scared. I gave you albuterol. I gave you an hour-long albuterol. I gave you Zopanex. I gave you a steroid. I gave you Symbicort. You've been taking your chromium sodium at home. All these things do not work. That's called a critical stage of asthma, which is called status asthmaticus. And it comes like that, right? Little or no warning, and then you go down fast. Hopefully you are near somebody who can get you to the hospital. 85% of the deaths had an episode lasting longer than 12 hours. So if you have status asthmaticus and it lasts for longer than 12 hours, 85% of them people die. That's scary, right? That's scary. Most common severe bronchospasm, mucus plugging leading to asphyxia. See, if those bronchioles, you want them to whistle because that means at least something's moving through. So say you have a patient who has an asthma attack and you listen to your patient's lungs and you don't hear anything moving. You give them a breathing treatment and go back and listen to them. Now you hear wheezes. Did they improve or did they go down? Was that an improvement or not? Improvement. Because first you didn't hear nothing, right? They were so locked down that you couldn't hear the breath sounds that were moving. It was moving barely, but you just couldn't hear it. But you gave them a nice saba, right? And then you listen to them for your post-assessment and you hear, whoo, whoo, whoo. That means it has opened up some more. That's a good thing, right? That's a good thing. If you started with nothing and now you hear wheezes, that means you are improving. You need to give them another one. Give them some more until you don't hear the wheezes anymore and you hear breath sounds, okay? You hear vesicular sounds. We all know that vesicular means normal, right? You're not going to see normal. You're going to see vesicular or adventitious, okay? Don't forget that, all right? Of course, the signs of status asthmaticus, breathlessness at rest. Dang, I said that. Breathlessness at rest, unable to speak in full sentences, wheezing during inhalation and exhalation. Peak expiratory flows are less than 50% of personal best, and pulseless paradoxus. A PEF or peak expiratory flow, that's that little peak flow machine that I showed you guys, and I'm sure he probably showed you. But the little peak flow where I told you blow into it and it's got the little colors on it. Yeah, that's a peak expiratory flow, a PEF. And so when you're trying to see if you're in a status asthmaticus stage, when you blow into it, it's going to be less than 50% of what your best is, right? You put the green on the best and the red on your lowest point that you've done. And so when you're not feeling well, you test yourself if you have asthma, right? Blow into it real quick and fast and then see where you are. If you are less than 50% of your lowest, you need to get to the hospital because you're about to have a status asthmaticus crisis. Yeah, it's in the notes. Less than 50% of personal best, your PEF. And pulseless paradoxus. Pulseless paradoxus. That's when your pulse changes on inspiration and expiration. So if you're feeling somebody's pulse and they take a breath and it changes, and they let it out and it changes back, that's pulseless paradoxus. Again, this is the asthma management here. Before we take a break, we'll finish up the asthma. Asthma, when we want to have a good plan for asthma, we want to have them go to the doctor regularly, right? And have them on a PEF, right? The peak flow. Make them do the peak flow. They'll have one with them at home, right? And we use the stoplight method. We have green, yellow, and red. Red being the low, red being the least of your best, right? Your least best. Green is the farthest you can do, farthest you've ever done, and the yellow is in the middle, okay? And you do that at home, okay? And then if you're feeling symptoms coming on, you do this. If you see green, that means you're 80 to 100% of where you should be. You have no symptoms, and medication can be continued or tapered down, right? If I'm supposed to take it every 4 hours, then I can stop taking it, or I can do every 8 hours or every 12. You know, I'm good, right? If you blow into it and it's yellow, that means you are between 61 and 79% of your best, and it may be an exacerbation. Temporarily set up in treatment, right? You might want to go and get you a breathing treatment, right? You get into the yellow, you need a breathing treatment, but you don't want to get into the red. But if you get into the red, that means this one says less than 60% of your personal best, right? Requires immediate medical attention if the short-acting bronchodilator does not work, All right. So if you get into the red and you give yourself a breathing treatment and you blow into it and it's still in the red, then you need to go to the hospital because status asthmaticus is coming. Don't panic, but it is coming. And so you go to the hospital, we can give you a lot of medicines and help prevent that from happening. Even if we have to put a tube down your throat and breathe for you. Okay, you might have to be intubated. Treatment, you don't have to worry about this one. This is just a nice little chart that talks about steps in treatment for children less than 5. Not on the test, but you can look at it for information. It's always good to have asthma information. But for treatment and prognosis, we're going to give pharmacologic therapy, right? Breathing treatments. Remove or try to minimize the triggers because the triggers could be inside, right? It could be stress. So you need to try to minimize those triggers. Get that stressful person out of your life. Get whatever that is and say, you know what? I ain't got the money for that bill. I just ain't got it. I got 5 candles I've been waiting to burn. So let it go because it's not worth dying for. Education, patient education is very, very important into understanding what level of asthma do you have and what to expect. Asthma education. You as a respiratory therapist can go into asthma education and you'll have it on the side of your name. Deasia Taylor, RRT, ACE, which is an asthma educator. Okay? And that you can go around speaking to all the different schools, go around all over the country speaking and teaching about asthma. It's very lucrative. A very lucrative job. Control is the best treatment. What's the best treatment for asthma? Controlling it. Keeping it from happening, right? Taking your chromium sodium like you're supposed to, taking your steroids like you're supposed to, stop smoking, get out of around people that smoke, get the stress out your life, right? We're controlling it by trying to prevent it. All right? Prognosis. Childhood asthma usually improves with age. Okay? A lot of people say, oh, I had asthma when I was little, I grew out of it, right? A lot of people grow out of it. Right? Severity of disease may be indicative of lung damage. You can damage your lung and lead to what? COPD. So asthma alone is not necessarily COPD, but asthma in conjunction with maybe chronic bronchitis, right, is COPD. Chronic lung diseases, right? Chronic, all the time, right? All the time. All right, let's take a break. It's 2:55. Let's come back at 3:05. I will stop the recording to 3:05, and we're going to come back into bronchiectasis. Bronchiectasis. There's only a few more. We got bronchiectasis, cystic fibrosis, bronchiolitis, and that's it. Okay? All right, stop the recording. All right, bronchiectasis. Bronchiectasis is the next C-babe disease from COPD. The definition of bronchiectasis is chronic dilation of bronchus or bronchi, usually in the lower portions of the lung, caused by destructive and inflammatory changes in the airway walls. So bronchiectasis is dilation of the bronchus or bronchi, okay? Dilation would mean that they're wider than they should be, right? The bronchi or the bronchus is wider than it should be, all right? Now, that widening can either be in one spot or it can be all over the lung. And it's different types of widening. It can be wide, small, you know, several types. It could be uniform wideness all the way through, or it could be like sacs, right? It's so wide it almost looks like an alveolar sac, all right? But it's not an alveoli. It's actually a bronchi or bronchiole, right? And that's a bronchus or bronchi, and that's bad, right? That's bronchiectasis. Now, You got local or diffuse. Local means it's right in one spot, or diffuse means throughout both lungs. The causes of the local bronchiectasis will be a foreign body, right? A foreign body that's inside the bronchus that's causing it to be wide, an airway tumor that's in there, or external bronchial compression, right? So a tumor or something behind the bronchi that's pushing it over, okay? Diffuse, so something that's local is something that's there, right? You have gotten something, some kind of a bullet fragment or some type of foreign object is there, a tumor is there, or some type of bronchial compression, okay? Diffuse means it's diseased, right? It's throughout the whole lung. So if it's diffuse, it's caused from some type of disease, right? And that would be cystic fibrosis, ciliary mobility disorders, also alpha-1 antitrypsin deficiency, and then infections like tuberculosis, the flu, measles, whooping cough. All those things could be the cause of the diffuse bronchiectasis. Huh? Alpha-1 antitrypsin deficiency. If you're tired though, you don't have to be in here. You can look at the recording if you need to. If you're tired, you can go home. You got that your homework assignment is already in there in the module if you need to. All right, so the classification, this is very important. Remember I told you it can be different types of ways. Well, the first one is called cylindrical. Cylindrical, also known as tubular, is the mildest form, okay? Airway wall is uniformly dilated, okay? Cylindrical. So cylindrical will be number B. Look at letter B. See how this one is evenly wide, right? It's wide, but it's evenly wide, right? It's tubular, right? It's tubular. It shouldn't be this big, okay? The bronchiole or the bronchi should not be this big. It should be smaller, but it's dilated, and it's dilated pretty much the same all the way through. So it's uniform dilation. That's called cylindrical, and that's the mildest form of bronchiectasis, okay? If you had to have bronchiectasis, this is the one you want. It's the mildest form. Then we have varicose or fussiform. Varicose, also known as fusiform or fussiform, right? It's thick varicose veins, right? Most severe case of bronchiectasis would be varicose. That's A. See that? That's A. That's varicose. Look how that looks. Huh? No, this ain't nothing. This doesn't have anything to do with stretching. It's just the dilation of the tubule. What? It's gonna stay just like that. No, if you got bronchiectasis, it's pretty much gonna be like this. You get a lung transplant. All right. So look at this one. Varicose. Look how it just looks nasty, right? That is the most severe form of bronchiectasis. So if they say, what's the most severe form of bronchiectasis? You would say varicose or fussiform. If I say, what's the mildest form? You would say cylindrical or tubular. Wait. Let's strike that. Varicose is more severe than cylindrical. I'm glad this is being recorded. Varicose is more severe than cylindrical, but the cystic or the saccular is most severe, okay? So look at my lips. Cylindrical or tubular is the mildest form. Varicose is more severe than cylindrical, so it's like number 2, right? Second level of bronchiectasis. And the third level and most severe form is cystic or saccular. All right. So look at A. A is your varicose part. Okay. That's the second most severe. Second most. All right. The first one is cylindrical or tubular. That's like mild. That's number 1. Right. If I got to get it, I'd rather have this one, which is B. That's tubular. Right. Tubular, also known as cylindrical. It's evenly dilated all the way through. Then as it gets worse, it's varicose or fusiform, right? This is the second most severe, right? Second most, okay? And then the most severe would be the saccular. Look at that. That's supposed to be a tube, but it's a sac, right? That is terrible. That is very, very severe bronchiectasis. So cystic or saccular, which will be this one right here, okay? These tubes should be tubular. It should be tubular, straight, right? Bronchioles, bronchi, but they're rounded. They look like alveoli, and they're not. This is supposed to be a bronchus or bronchi. If it's fat like that and made into a sac, that is called cystic or saccular, and that is the most severe form of bronchiectasis, okay? Progressive distal enlargement of the airways, third or fourth generation bronchioles, right? They become severely dilated at the bottom of the bronchiole. The airway wall destruction that results in sac-like dilations. They turn into sacs. So bronchiectasis has three types: cylindrical, varicose, and cystic. Cylindrical is the mildest form, varicose is the second most severe, and cystic is the third most or the most severe. All right. If we look at a CT, right? CT, this is not an X-ray, this is a CT of some lungs, okay? You look and you can see the bronchiole. It's thick, right? And it's wider than it should be. This is the tubular one here. These are the tubular. They should not look like that, okay? They should not look like that. You should barely see them, but because they're so fat and dilated, see, these bronchi and bronchioles are dilated all the way through. So that's called tubular bronchiectasis. That's the most mild one here, okay? Then you look at these three. Right here you have cylindrical, right, which is tubular. Same thing as over here. See how it's evenly dilated all the way through, right? So that's a way of looking at cylindrical. Look at varicose. You got some that are small and then they get big. Some that are small, big. They just different. Like you got small right here, then they're big, and then they go back down here. See that? They're small here, and then they get big, and then they go back to small down here. So they're multi, right? That's varicose. And then cystic is the worst kind. You have the tube, and it ends in a sac. See all these sacs? These are not normal. These should not be in your X-ray, in your CT. This is cylindrical. This is cystic or sacral, all right? Most severe case of bronchiectasis, okay? Down here, you can kind of see that they say the signet ring, the telltale sign of the tubular will be the signet ring, okay? They call it a signet ring. You know how you have a King Arthur of the British court or whatever, they have those rings, right? They have a one big gold ring with a big circle on the top, where they stick it in the and stick it in the wax, and they put it on there, have their sign on it. You know what I'm talking about? Just the kings and the queen. The king has a big ring, and he always has a big ring with a big circle on it. So when you look down on the CT, you see these circles right here. They call that the signet ring. So you can see the bottom of the ring there, and that will be the top. They call it the signet ring. Okay, that's what doctors have come up with. You're not going to be able to tell that in a CT, but you should be able to see this tubular here. See that? See how that's tubular, right? That's the least severe tubular. Look, that's a good looking one there. Tubular. They shouldn't see. They should kind of look like this. See this right here? That's how the bronchi should look on the CT. But when they're wide like this, they're wide all the way through like this. This is considered to be tubular, right? It's uniform dilation all the way down. Okay. And then, of course, the cystic or the sacs. It looks like a tube with a sac at the end. That is cystic or the most severe. This one we're here, these are sacs. Look at that. See that? They look like holes all in the lungs, right? These are cystic or sacral bronchiectasis. You need a lung transplant when you get that bad, okay? And they do lung transplants all the time.
do nobody else on the real test. Do it
You just get a whole nother set of lungs.
like a dead person.
Or somebody who donating their if they're dying from something else like colon cancer or dying from something that got nothing to do with their lungs, they can say, I want to harvest my organs. So when they're there, they're gonna come to you and ask you, hey, do you mind if we use his organs? Or on the back of your ID, they say, I'm an organ donor. Well, that's what they're gonna do. But when you about to die, they're gonna take if it's nothing else they can do for you, a team will come in and watch you, and then they have people fly in from all over the world to take your organs and take them wherever they're going. So like young people, in trauma, you have a lot of young people that die from wrecks, gunshots, got shot in the head, right? If he's shot in the head, he through, he gone, right? He brain dead, nothing working no more. But he got a perfect heart, perfect lungs, perfect spleens, perfect liver, right? They can use those if he wants to. If he agrees to that, then they can use those. They'll come in and get that and give that heart to somebody who's living, who needs it. Kidneys, all of that, right? You don't have to do it, but some people do. That's the only way you're gonna have transplants is because people do it. Okay. So bronchiectasis. Look at this one over here. This will be an example of this saccular or cystic or saccular. Look at these holes, these little sacs. This is a lung. This is a nasty lung. You remember yesterday when I showed you guys what a lung's supposed to look like? That pink, nice lung, right? But if you're a smoker and have COPD and have bronchiectasis, this is what a cross-section of your lung looks like. A cross-section is like a thin slice by a laser. They slice it and put it there to show you. This is what your lungs look like if you smoke blunts or if you smoke cigarettes. Just so you know, might not be this bad yet, but it's going to be. It's going to be. All right. So another telltale sign or telltale sign of bronchiectasis will be the secretions that come out of that person's lungs. When I sucks you out, right? The suction containing contents go into a suction container. If any of you have worked in a hospital or been in a hospital room, there's a little red top container on the side of the wall that you suction things out of the patient with. It goes into that little container. Well, it usually just looks like a bunch of sputum, nasty, saliva, blood, whatever that's in there. But if they have bronchiectasis, that same secretions, they split up into 3 layers. And so when you look in the container, it's got 3 layers of sputum, right? You have a frothy layer at the top, that's frothy like beer. Then you have a micropurulent, which is mucus and pus in the middle. And at the bottom is purulent with pus. So there's a whole bunch of pus and thick pus that's heavy, right, at the bottom.
So it would be like a funnel thing, a funnel with like the process down through.
No. This is just the stuff that comes out. When it comes out, when we suck it out of your lung, like you coughed up some stuff and we sucked it out of your trach, your whatever, and it goes into this container. When it first goes in the container, it's just mixed. But over time, they separate like oil and water, right? You know, you got some oil and water, shake it up and put it somewhere. It's going to be together for a minute, and then it's going to separate. The water will be on the top, and the oil will be at the bottom, or vice versa, however that works. But it's separated, right? So when you look in the container, it's going to be 3 distinct layers. So bronchiectasis will have 3 distinct layers in the sputum in the container, right? So that's just one way of you to tell, huh?
Do you just leave it there just so you can see if this what it does?
Nah, you're going to throw that stuff away once you're going to know he got bronchiectasis. But that's just another telltale sign, right? If you go into the room and you see that, and you've been suctioning the patient out and y'all notice, a day or so later that his secretions are splitting up into 3 layers, that's a telltale sign of bronchiectasis, okay? That's just one of those things that you say, I know you by that birthmark, right? That's a telltale sign. Or his voice or his laugh. If I hear that laugh, I know that's my cousin. You know what I'm saying? That type of thing. That's just one way of knowing for sure that it's bronchiectasis. It also manifests with VQ mismatches, hemoptysis, reoccurring infections, and digital clubbing. Digital clubbing is a phenomenon that many people don't know of, but when the fingertips look like drumsticks, you have a regular fingertip, and at the end, what a nail is fat. It's like little drumsticks, right? That's called digital clubbing. That's a telltale sign of COPD, especially bronchiectasis, okay? Again, CT is how we diagnose it, right? We're gonna do a CT and look at it. See how you can see this one? He has tubular. See how tubular? It looks like tubular here, but looks like it might be varicose right here. You should not see this. When you get an X-ray, you shouldn't see all of this, right? It should just be the black and the ribs, okay? But because you can see this, it's because his bronchioles and bronchi have been dilated and they're thick. So you can see it now, right? You should not see this on an X-ray or CT. This right here is an X-ray, but you diagnose it with a CT, what we showed you when you're looking down from the top, right? But this one right here is an actual X-ray, and you can see the tree. You should not be able to see the tracheal tree, right? That stuff shouldn't see it. But because you can see it, means he has bronchiectasis. So you get that X-ray, ooh, bam, in your face, he has bronchiectasis. And then we will get a CT to be for sure which type, right? Does he have saccular, does he have fusiform, or does he have tubular? And then we can treat him right. Because if he has the saccular, right, the saccular one, which is the most severe, I don't want to be treating him for the tubular, right? I don't want to give him a little treatment for the tubular when he's dying from the saccular. I need to know which one am I dealing with, right? I need to know, okay? And so we do that. We do bronchogram, bronchoscopy, chest X-ray, and CTs. That's how we diagnose bronchiectasis, right? Also looking at the sputum and that's been collecting after you suck him out. You can diagnose it that way too. Treatment, aggressive pulmonary hygiene, bronchodilators, if it's a reversible component, right? If he's having wheezing and stuff like that, you can do bronchodilators to kind of help the wheezing, but you can't fix the bronchiectasis with no medicine, right? Antibiotics, because a lot of the, we said pus is dead what? Pus is dead white blood cells, and the white blood cells only come out when there's a what? Infection. So if you got pus all in your lungs, that means there's an infection there. So we would give antibiotics because white blood cells only fight bacterial infections. So if I see pus, that means there's a bacteria there that has killed the white blood cell, right? And the only way to kill that bacteria is an antibiotic. Then you can do lung resection. That means if your left upper lobe, or let's say your right upper lobe is good, your right middle lobe is infected with bronchiectasis, and your right lower lobe is good. We can take the middle one out and connect your upper and lower together, right? And resect them and get rid of the bad one, right? You can do a lobectomy, which takes that lobe out. If it's only in one lobe, we can remove that lobe and you will have one less lobe. Now, yes, you will be able to tell the difference in your breathing, but you'll still be alive. All right, cystic fibrosis, almost done. We already learned that cystic fibrosis is a very, very debilitating disease. It's hereditary. Cystic fibrosis is a hereditary disorder that affects the exocrine glands, and it causes production of thick mucus, which leads to the blockage of the pancreatic ducts, the intestines, the bronchi, and results in respiratory infection. So not only does cystic fibrosis affect the lungs, but it affects the pancreas, it affects the intestines, right? It affects the reproductive organs as well, right? You have thick mucus that is in the way, right? It's all in the pancreatic ducts, it's in the intestines, right? So when it's thick mucus on the intestines, they can eat the nutrients, but guess what? It never gets absorbed. That's why they don't live long, because they can't take the nutrients in. You eat food and you get nutrients from the food, but if you have cystic fibrosis, your intestines are blocked by mucus. So the food goes in, but it comes right back out. It never gets absorbed. And so they usually look malnourished, right? Skinny, sickly looking, right? And they always have a lot of treatments. They got a lot of inhalers, MDIs, that chest vest. See that baby on a chest vest? That seems like that would be so debilitating at such a young age. She gonna know. You don't grow out of it. Now, they have things that have medicine, and respiratory medicine has improved where they live longer, but they still die from cystic fibrosis. It's sad. It's sad to hate to go through that, right? You hate to go through that. It is one of the most common life-limiting autosomal recessive diseases, right? It's immune. It's a genetic. It's a genetic disorder that you get at birth. Very, very common, life-limiting. See, you can't really live a good life. You got to remember I showed you have a whole bag of stuff you got to do every day just to be able to breathe and function, to get rid of that mucus, right? Drainage, CPT, PEP devices, shaking vests, flutters, medicines, mucolytics, all day, every day. All right? It occurs in approximately 1 in every 35,000 newborns, 3,500. So that's a lot. 1 in every 3,500. We have thousands of people born every day. It affects approximately 30,000 people in the United States. You don't have to worry about all of that. And the majority are Caucasian. Very rarely will a black child get cystic fibrosis. It's a Caucasian disease. Like sickle cell is mostly a African-American disease. Cystic fibrosis is mostly a Caucasian-American disease. This is just a little chart if you want to go back to kind of look at how it happens. You can either be a carrier or you can be a full-fledged cystic fibrosis person, right? If you and your, so say 2 white people get together and both of them happen to be carriers of cystic fibrosis and they have 4 children, one of them will probably be fully fledged cystic fibrosis. One of them will not have nothing and 2 of them will be carriers. See that? If you have one Caucasian that has it full-fledged cystic fibrosis and then other one is just a carrier, then if they have children, 2 of them will have cystic fibrosis full-fledged and the other 2 will be carriers. Okay, so that's just kind of showing you how it is, okay, how it spreads. So you don't have to know this part, right? You don't have to know all of this. I'm not gonna ask questions like that. You just need to know it's a genetic disorder. Abnormalities in respiratory, digestive, and reproductive tracts. Let's see. Yep. All you need to know on this one is pretty much that digital clubbing is present in many of these patients, but it's not a universal sign, okay? Digital clubbing, I told you again, that's when the fingertips look like drumsticks. Okay, you need to look that up on YouTube, on Google, when you get a chance to type in digital clubbing, and you can see some of the pictures of that come from COPD. Cystic fibrosis, what I need you to know about that one is that it is hereditary. It is a disease that affects the pancreatic and the digestive or bronchial ducts, right? And it causes thick secretions that's hard for them to get rid of. And because it is on their intestines as well, when they eat food, they can't absorb those nutrients, which make them strong, right? They fail to thrive. That's usually what the diagnosis is, failure to thrive. They just look sick. They look malnourished. They're always coughing up thick stuff, right? And they used to live like till 10 or 15. I think they live up to like 40 years old, 50 years old now, right? And then I need you to know, how is it diagnosed? How do we know if the child has it? It is confirmed by a sweat test. A sweat test. It's also confirmed by PFTs, which have an increased FRC, TLC, and RV, right? Same kind of test for any COPD patient. Your FRC, their TLC, and their RV are going to be bigger than yours because they can't get the air, what? Out. So their FRC, TLC, residual volume is always higher than yours because they can't get it out, right? But the way we do the sweat test is they taste the side of the baby's face. If you taste the baby's skin on his face, it tastes sweet. It tastes sweet.
Like literally the person.
Yes, a parent. The parent would know, that's one way the parent would do it, would taste the side of the baby's skin, their sweat. Their sweat is kind of sweet, a really sweet taste. That's a sign of cystic fibrosis. That's a sign, it's called the sweat test. Okay, you can look further into the sweat test of how it tastes and how they know and all of that. But you just need to know it's confirmed by a sweat test and PFTs. Also, positive family history. If somebody in the family got it, mom and daddy got it, or carriers of it, then yeah, you probably got it. Okay, so we taste your face, right, and we know it's sweet, and then we find out, oh, mom's a carrier and dad has it. Well, then yeah, that's what you got. Okay. They have recurrent sinus or lung infections, chronic cough, nasal polyps, digital clubbing, malnourishment. See, poor weight gain, great appetite. They can eat 10 Whoppers, but it just comes right back out. They fail to thrive because they cannot absorb those good old nutrients from them Whoppers, right? If Whoppers got any nutrients, they can eat. They're not like, I can't eat, I'm not hungry, right? No, they eat. They have a great appetite, like me and you, or me at least. But they don't absorb the nutrients, so their muscles don't develop. Their body doesn't develop like it's supposed to. In 1938, children lived 6 months with cystic fibrosis. That was as far as they would live. By 2002, the median age was 31. By 2012, the median age for living for cystic fibrosis is 41 years old. You don't have to know those either. All right, how do we treat it? You see this bucket right here? That's how. That's how. Might as well. You already know the medicine we use for cystic fibrosis, which is Dornase alpha, Pulmozyme, right? We use mucolytics like Dornase alpha. This is the telltale sign if that patient has cystic fibrosis, is if they're taking Dornase alpha, right? They may also be taking Mucomyst and hypersaline, right? Hypertonic saline to help break down that mucus. Also, oxygen, bronchodilators, good hygiene. Remember, I told you they're using the CPT, the PEP, the flutter, aquapella, the chest vest, everything. Antibiotics, steroids, vitamins, and lung transplant if it's really, really advanced. It's just a sucky life, right? It's a real sad life. And if you have a patient with cystic fibrosis, you need to do your very best to make their life easy, okay? Treat them well, do the treatments, don't cut corners with their treatments because they don't have long to live, right? It's not going to be just a normal little run-of-the-mill breathing treatment. Be in there, talk to them, give them the treatment. Make sure you do everything you can because you may look around and they're gone. All right, last one, bronchiolitis. Bronchiolitis comes from RSV, respiratory syncytial virus. When a baby gets the respiratory syncytial virus, it causes them to have bronchiolitis, which is inflammation of the bronchioles. Bronchitis is inflammation of the bronchi, and bronchiolitis is inflammation of the bronchioles. All right? It comes from RSV. All right? It affects 1 in 10 infants. Usually has a good prognosis, but 1% will die from RSV. They're most successful at a very young age, right? Very, very young. And if they already have immunodeficiency problems, heart disease, CF, asthma, or BPD, if they have anything like that and they get RSV, then they may die, right? But if they're a healthy baby and they just happen to catch that, only 1% will die. And we treat RSV with what medicine? What medicine do we treat RSV with? Ribavirin. And we have to give ribavirin in a SPAG, the SPAG. Small particle airway generator. Yep, a SPAG. Good. Bronchiolitis is usually a viral inflammation of the bronchioles caused by the RSV virus, right? Acute process that occurs less than 2 years of age, peaks at 6 months. Manifestations: increased mucus, cough, wheezes, edema of the small airways. The baby may have retractions. That means his stomach is sucking in when he's breathing because he's have his accessory muscle. Retractions means he's using his accessory muscles to breathe. All right, his little nose might be doing this, right? nasal flaring, things like that. Lets you know he's having trouble breathing. All right. And a chest x-ray may show hyperinflation from air trapping, areas of consolidation if it's severe. How do we treat it? We already said we give oxygen, of course, high flow nasal cannula if needed, aerosol tent. We might even use heliox if we have to. Bronchodilators if there is bronchoconstriction, right? It might not be bronchoconstriction. If there's no bronchoconstriction, you don't use a bronchodilator, okay? For what? He doesn't have bronchoconstriction. But bronchial hygiene is important. CPT is discouraged because he's a baby. You don't be hitting on a baby. Nasal suctioning with the bulb. See that bulb there on the right? You stick that bulb in, you all know to have babies, you suck that stuff out. You want to get it out, clear them up, right? Sometimes we squirt that little saline up the nose, right, to help it flow on out. Some of them have done racemic epi, right? And that's just a trial. But the main thing is an antiviral medicine called ribavirin. And we use it in this SPAG generator right here. This is a SPAG generator, right? Small particle airway generator. And we use the ribavirin medicine in a SPAG and put that through the tent, right? And the baby takes that treatment. Antibiotics, if they have secondary infections, because antibiotics don't treat viruses. Don't forget that. But if they have the virus and a secondary infection, then we may want to give a little bit of antibiotic. All right. That's obstructive diseases. Those are your obstructive diseases. Okay? Tomorrow, we will do restrictive diseases. We will do restrictive diseases. If you want to go ahead and look at the PowerPoint, it's available. This PowerPoint is available. This lecture will be loaded by the end of the day today. And then tomorrow's PowerPoint, restrictive lung disease PowerPoint, is already available. If you want to be looking at that, reading upon it, studying it, so then you're ahead of the game, right? I can't hear you, Rayana. You talking to me?
No, I was on the phone.
Oh, okay. So, yeah, so tomorrow we'll be doing that. The homework has been put into the Canvas for tonight. It's already in there available for you. So you're welcome to knock that on out. Have that done by midnight.
Mr. McCarthy,
Yes.
can you go over the homework real fast?
Yeah, I am. Once I get through with the part, let me finish that, close this out, then I'll go over with you, okay?
Okay.
All right. So, yes, tomorrow is that day. Be looking in your syllabus for the lab day. It's coming up. We're going to come in and do hyperinflation lab. So, this is the last one, guys. You got this one. You got a couple of makeup days in there, but the oral and the final are coming up after this test. So after we take this test, don't even count the CPR, because, I mean, everybody's going to get at least an 84 on the CPR. You need to be focusing on your oral and your final, which has everything you've learned. All of those normals, all of those formulas, the formula for minute ventilation, alveolar minute ventilation. How do I find tidal volume? How do I find this and that, right? The alveolar air equation, which is the P bar minus water, all of that. It's going to have those problems. What is the normal potassiums and the chlorides and all that stuff, guys? You have to have been studying. Start focusing on that. Yes, focus on this right now, but you need to be dipping into that because it's coming up, all right? And it's very heavy. You can pass all the way through, and if you bomb that final, it puts you below a 75. You'll be repeating 210 again, all right? So work hard. I will see you guys tomorrow, and we will be doing restrictive lung diseases. Have a good day.